Fab.
Yes.
So I'll just kick off then, shall I? Is that all right, Lauren? And just first of all, welcome everybody. I can now see at the side the number of participants, which is great. So it's good to have folks joining with us on this joint seminar with the Institute of Health Records Information Management. I always say IHRIM's, I think, one of the oldest professional bodies within the Federation of Professional Bodies. So it's always good to work with IHRIM because of the depth of knowledge that the body's got on, particularly on information management and the medical record. And so I'm delighted today that we're doing this joint seminar on the patient records and the misfiling of information. And I think there can be a bit of a misnomer, can't there, that somehow or other because we've moved into digital, that misfiling doesn't happen. But of course, we know it does. And so many of the principles that apply to the medical record also apply to the electronic patient record. So it's a great opportunity just to reflect, I think, today on what those issues have been historically and how they've been dealt with, and then apply some of those and learn from some of those principles as they apply in our new digital and electronic world as well. So a little bit of background on FEDIP for those who don't know, but FEDIP is the body that brings together the different professional bodies and has got responsibility for standards in this whole area. And one of the things that we're very keen to do is make sure that we are using the expertise of the people within the professional bodies to provide guidance and to raise the standards and raise the level of the practice of those standards by various activities. And this is just one way of us doing that. And so we're delighted that we got Lauren with us, who's the Director of Communications for IHRIM, and also hugely experienced in the area of clinical notes and clinical coding. And so I'm delighted that she's able to give this talk. And one of the things that we want to do, hopefully there's lots of people who are joining the call who want to know about this subject and who already belong to a professional body, whether that's IHRIM or one of the others, and that's great. We want to encourage that. But if you don't belong to a professional body, then it really would encourage you to get involved with this important work and be a participant really in shaping things as they go forward. And then if you belong to a professional body, then you can also join the register as long as you meet the standards. And if you want to know more about either of those things, then please feel free to contact either FEDIP or IHRIM via the website or by putting a note even in the chat and the questions today. So without saying anything further, I just want to hand over to Lauren and hope we will enjoy what you've got to say to us today, Lauren. So thank you very much for doing it and look forward to hearing what you've got to say. Thank you.
Thanks, Andrew. So I'm just going to share my screen, which is always a little bit temperamental. So fingers crossed, you can all see my presentation now. So I'll just introduce myself for those that don't know me. My name's Lauren and I'm Director of Comms for IHRIM. I also will work full-time for the NHS at Rotherham NHS Foundation Trust. I'm the Clinical Information Assurance Lead. I'm a qualified clinical coder and coding team leader. I joined the NHS back in 2008 as a clerical assistant before moving into clinical coding in 2013. I've never looked back. So just before we get started, I just wanted to tell you a little bit about IHRIM. IHRIM is the professional organisation for people working in health informatics, be it health records, patient services, clinical coding or information governance. IHRIM is primarily an educational body and examinations at various levels are carried out. These include health informatics exams and the National Clinical Coding qualification. The team is made up of 2 full-time employed office admin staff and the rest of the team are all volunteers alongside their NHS roles. There's a wealth of experience in the team. It includes a data quality manager, records manager, data protection officer, head of information governance and records, alongside clinical coders. Despite vigilance when filing information in records, mistakes can occur. IHRIM have put together some guidance for managing and correcting wrong information in records to support professionals in making corrections following errors. In the next few slides, we'll have a look at some guidance which has been published on the PRSB website and is available to download. I'm not going to claim that I'm a medical records manager or an expert in this field, but as I do deal with medical records on a daily basis in my NHS role, I am aware of the guidance, and everyone that works with records should have a level of awareness too. So the Data Protection Act is a UK Act of Parliament which updates data protection laws in the UK. It is a national law which complements the European Union's GDPR and replaces the Data Protection Act 1998. The Data Protection Act requires organisations to ensure the personal information that it holds is accurate, not misleading, and if any information is identified as such, that reasonable steps will be taken to correct or erase it. Individuals now have free right of access to their own records, and this is generally perceived as a good thing, although it requires robust and transparent information and data management processes to be in place. There are occasions when things go wrong and errors may occur. This can manifest itself in several ways. It could be a wrong document which is filed in another patient's record, be that paper or electronic. It could be wrong information within a document that belongs to another patient. And it could also be wrong information that's recorded incorrectly, but for the right patient. When information has been identified as being in the wrong record or incorrect information has been recorded against the right patient, the very first thing that you should do is raise an incident on the organisation's incident reporting system. An example of this, which a lot of trusts use, is the DATEX system. This is done for several reasons. It recognises that the incident has actually happened. It also allows for an investigation as to why and where the incident happened. It provides information to be able to monitor the situation to see if there are any trends. It also allows the records management team or equivalent to rectify the incorrect information. Management of records can be managed in a number of different organisational departments, but the rectification of incorrect information should sit with the appropriate team with the necessary skills and knowledge. So, we've reported the incident. What do we do next? What we absolutely should not do is remove the information. The reason for this is that you will not know if any treatment, procedure, or care is being given based on the incorrect information. Once you have recorded the incident on the trust reporting system, you should send the physical records to the records management or data quality department to manage with the author or their representative the appropriate actions taken in line with the duty of candor. Once information has been identified as recorded in error, there should be a mechanism in place for the records management or data quality teams to manage this. So IHRIM's guidance document, which is available on the PRSB website, contains 4 separate case studies, which provide step-by-step advice on how to manage each error. I'm not going to cover all 4 of these case studies today, but they are available on the PRSB website or in the slide pack, which you'll get at the end of the webinar from today's session. 2 of the case studies are based on paper records and 2 are based on digital records. I've chosen one of each to go through today, so we'll look at a paper record first and then a digital record after. So case study 1 we'll have a look at. So this is where a document is incorrectly filed in a patient's paper records. If the incorrect information is a single document and the information recorded on both sides belongs to another patient, then remove the document, identifying where you have removed it from. We'll cover in steps 4 and 5 how this is done. So you would then photocopy the document after removing it from the record. On the original document, you would place a label. An example is provided on the slide. On the photocopied document, you must redact the patient's details so as not to breach confidentiality within the patient record that it was found. Again, an example label is provided with the level of information that you would require. File the photocopied document, which is now redacted, back into the record where it was originally filed. File the original document in the correct patient's record and inform the clinical lead that this event has occurred. You must keep a record of both patients' details. It is recommended that you record information about this data incident separately. For information, the date you identified it, the date of the recorded information, the type of document and information, and the setting of the information. This will provide evidence of the episode, which will stimulate discussion at health records group or information governance group meetings on how this error occurred and how it can be avoided in the future. The next few slides review case study 2, which gives guidance as to what you should do if you do find part of a document which contains information about another patient, but we're not going to cover this today. The management of incorrect data within a digital electronic record will vary depending on the EPR supplier's software. In principle, there are 2 elements where data errors can occur: within a digitised paper document or incorrect data within the EPR or FEDIP systems. So now let's have a look at what we should do if we find an error in the digital record. In the same way that an incorrect paper document should not be removed from a paper record, in a digital record, the incorrect information shouldn't be removed either. If a digitised document has incorrect information within it, this needs to be clearly marked as incorrect. Find the incorrect document in the EPR system and annotate the document by adding an appropriate statement. We have some examples of these up on the slide. Any personal information on documentation relating to the incorrect patient, so a hospital number, NHS number, these should be redacted. A date must be added to any of these statements identifying when the information was rectified. The statements on the slide should also be added as a watermark to the document or documents in question. So we've got another case study there, which we're not going to cover today, but will be provided in the slide pack. So I just wanted to go through a few of the benefits of being a member of IHRIM. Membership of the Institute means part of an internationally recognised professional organisation. IHRIM's collaboration with FEDIP gives members the opportunity to be proactive with regard to legislation, developments and compliance with their organisation. You can also benefit from free places and reduced rates for attendance at conferences and masterclasses. You'll get access to the privacy and data protection journals. IHRIM members have access to these through the IHRIM website. There are also additional areas of the IHRIM website that are not accessible to non-members, and these include all of IHRIM's past papers, which are copyright of IHRIM. IHRIM is the only professional organisation offering comprehensive qualifications for health records and health information professionals at all grades. An IHRIM qualification offers a competitive edge with employers, potential employers, colleagues and peers. IHRIM qualifications are recognised as the benchmark of professional excellence. If you would like to become a member, you can do this by visiting the IHRIM website and downloading an application form. You can also email the office, or my details are provided in the slide pack as well, and I'll be able to give you further information. If you have any queries at all relating to managing patient records, you want advice based upon today's guidance or presentation, please do not hesitate to get in touch, and we will respond to any queries you may have. IHRIM's next FEDIP session will be delivered on Monday the 7th of March at 12 o'clock and will be based on clinical coding. You can also connect with us on social media, and we use our platforms to share best practice and news articles. We also publish the link for our monthly newsletter. You don't have to be a member of IHRIM to view our newsletter, which is shared on social media. Thank you for everyone's time today. I hope you've enjoyed the presentation. I think Sarah's been managing the chat box if there's been any comments in there.
Somebody might be furiously typing, so I'll just ask you a question, Lauren. So in your experience, are you seeing a lot of errors happening or misfiling in electronic patient records?
Yeah, I'd say it's just as common in paper records. And I think, like in the beginning, in your introduction, I think people thought when we would go digital, those errors wouldn't occur, they'd just go away. But actually, I think there's more errors happening in digital records from my experience. I think it's easy. I think if you're in a patient, I mean, I'm not sure about who's entering the data, but I imagine that they're extremely busy. And I wonder if they're doing the same checks as they would with a paper record. I think sometimes a digital record isn't acknowledged that it is still a medical record and it is still a legal document. But we are at Rotherham, we've got quite a good process in place where we do use watermarks, and it's marked quite clearly if there's an error. But sometimes, being a clinical coder at the end process, you have to report it before the watermarks appear. So you have to be extremely vigilant.
And it does strike me exactly that. I've seen lots of errors made in people logging into a patient's screen and then treating another patient and then coming back to the screen and then assuming they're in the new patient record, or someone's gone in and changed the context of the record and then they're typing something in. Or and of course the danger there is that, of course, the record is now available right across the health system, isn't it? And becomes almost, people believe, the computer says no, is the famous phrase, isn't it? The computer is saying something and suddenly we find that we believe it a little bit more strongly than perhaps we should. So have you got any sort of thoughts on how we do something about raising that awareness of the reality that the EPR is now becoming the standard for medical record, and just raising the profile really of that?
I think it's a combination. It's always ensuring that you're reporting the error, because I always have a concern that if people are too busy, they might just pass over it, might not realise how important it is to report the error. Reporting errors take time, but if you don't report it, nobody knows it's happened. So that's one of the big things. But I also think it's sharing the guidance and working with teams. I mean, it's getting that message out there of what to do if an error occurs, because we all know that they occur. You're never going to stop that. It's how we react to them and what we do when we come across them. But like I say, the guidance which has been published on the PRSB website is available to everybody. We can share the link with Sarah to go with the slide pack as well for everybody that's attended today. But obviously, any further questions, if you want to email them through, we have got a big wealth of within IHRIM, the team. We've got a lot of records managers, data quality managers, and they'll be able to give you some advice.
No, that's great. So there's a resource there now within IHRIM to help with you.
To tap into.
Yeah, there's a question from David Dawes, a name I know. What is your advice on supporting the mandate for data quality improvement within an organisation?
Oh, that's a good question.
There's a good question, yeah.
There is. I might liaise with Kim Bellis and Lynn Snow on that one and come back to you, David, if that's okay. If you could pop your email in the chat and I can get back to you on that. Oh, I've just seen Sarah's put my email in. That's helpful. And
David has said yes, he's got a thumbs up, so that's great. So we've also got another question from Tracy. There should be audits carried out to ensure the data is accurate. It shouldn't fall to the coding department to pick this up. Yeah, no, I'd agree with that. Also lessons learned. Yeah, I know. I think that's a great point. It's both a question and a point, isn't it? Which is one, and I think part of this answers David's question as well, is making sure that we have got audits going on. I can well remember the days when we instituted sort of audits of medical records, and there was a sense in which there was a bit of drama about that, because you had to go and pick the notes and put them in a place, and a team would come in. And I think that sort of occasion of doing audit has disappeared because we can do electronic audits in a different way. But I think it's easy then for that to go under the wire and people not to realise that we're auditing, or we should be auditing. So I totally agree with that point, basically, that there should be audits, and that's something I think perhaps we ought to look at as professional bodies, about how we have
a really good point. Yeah,
standard audits. So any thoughts on that, Lauren? On
I think that's a really good point. Obviously, coders aren't the only ones that pick up errors. It does often fall to them, with us being like the last step in the line, the last chain, sorry, we're the last people that review that. And as we review the whole record, it's highly likely that we're the ones that would pick it up. But I think stressing maybe that audits are important, that's definitely something that I will probably take back to my trust and ask if, are we auditing digital records? Because like you say, we were very aware that they did that of paper records, but is that taking place with digital ones? I'd suspect it is, but maybe just confirmation, reassurance. That's a really good point, Tracy.
Yeah, I think there's something for me as well. And very often we look at data quality, don't we, in looking where the particular fields match, and in many ways in electronic records you can do that sort of validation on data entry, can't you? So you're not allowed to put in a field that's completely wrong, whereas in the old medical records you could write obviously whatever you wanted. So I'm very well aware that there's been sort of audits of that kind of thing electronically as well. But it does go to a point, doesn't it, about how we should be setting some standards, I think, around how often audits should be occurring. And I think the other good point there is about lessons learned. And very often they're process errors, aren't they, that people don't think about how they use the electronic record. And as a result of that, they open themselves to the kind of errors that can occur. And we kind of need to design our processes to make sure those don't happen. And sorry, I'm going on now a bit, Lauren, you can have to shut me up in a minute. But there's a bit for me around, very often people get fed up with being logged out of systems, don't they? So, if you log people out every minute, people get fed up and they don't want to record information because they're logged out. But then if you allow people to stay logged in for an hour, you run the risk in process terms of someone else turning up at that PC and entering data under a different name, or indeed going back to the wrong computer, assuming they logged into another patient and recording the wrong information. So there's something how you get that right balance of encouraging people to participate in keeping the note, but also making sure that the process doesn't allow them to misfile information.
Yeah.
So we probably do with some guidance. Yeah.
Yeah, that's a good piece of work. Yeah. Yeah.
So anything else anybody would like to ask Lauren, then feel free to type the question in as I'm speaking now. But if not, then Lauren's email address is there. You can get in contact with IHRIM, who produce a load of advice, and I'm pretty sure would be really glad for people to participate in this debate as well. And maybe it's one of the themes that we need to pick up as a group of professional bodies, to think about what should we be saying to employers, to trusts and health organisations about record keeping. And I know IHRIM's got a load of information, and perhaps we need to highlight that a bit more and flag it up to organisations. So I can see VJ has put a comment in, agreed. Yeah. Sorry, I'm reading, which is not a very helpful thing to see me reading, is it? But I thought if I read it out, everybody's probably doing the same thing. But yeah, that's absolutely true, isn't it? That processes can mitigate it. But again, linking back, as you say, to the trust pairs, to NHS number, there's a whole load of potential verification stages that we ought to be ramping up, aren't there, over time, I think. But clearly, if you're in a hospital, the trusted PAS system is a key part of that. And again, we've seen lots of errors occur maybe because the wrong information is in the PAS system. So, and it goes to the whole thing of how do you keep addresses up to date, and who's got the latest copy of addresses, where's the master patient index, keeping that information, all those kind of things. So there's lots of things here there to consider. Thank you. So yeah, so I would encourage you, again, get in touch with Lauren, get in touch via our websites as well with FEDIP. These are some of the areas that we'd like to see developed. And again, we need people's active participation to develop some of this guidance. And again, we want to pick a few key themes to be taking to the NHS as a grouping of professional bodies, in a sense, to start a few campaigns around some of this stuff, because it's very easy, I think, for some of these key issues to drop off the agenda. And I certainly, it feels to me a little bit that there was a great emphasis a number of years ago about the manual record when we were trying to improve the record. And that seems to have gone down with the electronic record. So I think it's time then that we raised that flag again and promoted this whole issue of the data quality and the potential misfiling, and the way the processes and validation checks and audit can actually help us get better quality data, which of course is vital, isn't it, at the end of the day for patient care. So that's great. Good. Okay. Well, Lauren, any final words from you?
No, just get in touch if you've got any questions. We're here for you. We're here to help you and offer some advice. Thanks everyone for attending today.
Yeah, thank you everybody, and thanks for coming. Again, there'll be more information on the FEDIP website as well about some other webinars that we'll be doing with some of the other professional bodies. We've got one a month coming up to try and get a range of different viewpoints and different things that we can start to promote and work on. So thanks very much, and we'll just end at that point. So, okay.
Thank you.
Thank you.